Good. Well, welcome everybody, and yeah, good to see some old faces. So thanks for joining us. We've got quite a lot of interesting stuff to talk about tonight. So yeah, I think we're all hearing the buzz about the GLP-1 drugs, more accurately, the GLP-1 receptor agonists. And we're going to be encountering clients who are using these particular medications. And I think it's only going to get to a situation where we're seeing a lot more of the use, whether it's full dosing, microdosing, and as the field develops. So I think it's a great idea for us to familiarize ourselves with some of the aspects of these medications, but also understanding how the work that we're doing with photobiomodulation and also with the vibration plate can really add some value to individuals who are on these medications, also to individuals who perhaps want to have weight loss or options for managing obesity, but they perhaps don't want to use the GLP-1 agonists, and also for individuals who perhaps have to come off these medications or have decided that they want to look at other options. How do we support and how do we understand this process? So we know that these GLP-1 agonists are a game changer in terms of obesity. We've all heard about fantastic results that people have got. Many individuals have really had life-changing experiences. We've also heard of all the side effects. There are various court cases and litigation around some risk factors. So certainly a game changer. Can we in some way support individuals to optimize the benefits and mitigate some of the risks? So that's really the question that I'm going to be interrogating this evening. And let's see how we can work with our clients who are using these particular medications, but also for clients who perhaps have had to come off. How do we avoid the rebound? And then do we have, as a population, a GLP-1 deficiency? So why are we using these drugs? Why are we needing them so much in this day and age? So we'll touch on that a little bit as well. But something that we are acutely aware of is the reality that obesity is a very serious multi-system dysfunction. And there are two key things that stand out, two key challenges that stand out when we look at obesity. And one is that we see underlying mitochondrial dysfunction, and the other is that we see chronic inflammation. And we know that perhaps the starting point of obesity is insulin resistance, and that insulin resistance begins in the skeletal muscle. So here, at the level of mitochondrial muscle function, we start to see a breakdown. And essentially, we've established that diabetes starts in the muscles. And secondly, we have established that diabetes is a mitochondrial dysfunction. And then thirdly, we know that it comes with a lot of chronic inflammation. So if we're thinking about photobiomodulation, we are well positioned to help manage mitochondrial dysfunction and chronic inflammation. So that already should start making you think about the benefits of the modality that you're offering. And we will come back to the slide, but we know that the immune system is in a hyperinflammatory state. The signaling, particularly from the macrophages, which is the first start of an immune trigger, immune response, there's an imbalance. And we're getting a lot of, not only with our more specialized immune cells, but also we're getting a what we call the inflammasome pathways triggered, and that's another inherent inflammatory system that gets activated. We know that the mitochondrial dysfunction that we see in obesity is not only involving the skeletal muscle, but it's also then having its impact on liver function, pancreatic function, and then fat metabolism in itself. So let's see where we're going to go from there. And really just a reminder, when we're looking at the problem of obesity and excessive fat accumulation, these are all of the risk factors that are coming into the picture. And we might not think about it, but excessive fat accumulation has an impact on the skin, and not only in terms of the fact that you have a much bigger surface area of skin, but some skin-related conditions are related to obesity. We know that there's mental health issues. We know that there are obesity-related cancers. And besides the metabolic aspect of the condition, there are cardiovascular, gastrointestinal, microbiome changes. So obesity, again, is a multi-system condition. So let's look at these GLP-1 agonists. So they came into play well over 10 years ago in the treatment of diabetes. And we, in our own bodies, we've got an endogenous GLP-1 and another glucose-dependent polypeptide. And they are what we call insulin-like hormones or incretin hormones. So they're doing things to our blood glucose. GLP-1 is secreted in the small intestine, and it is secreted when you eat anything that turns into glucose. And it is inactivated by something called dipeptidyl peptidase 4. And this enzyme that deactivates the GLP-1 that is secreted, it deactivates it in about 4 minutes. And the GLP-1 that is secreted after our food has reached the small intestine, it is going to alert all the other organs to the fact that blood sugar is going to rise, so we need to respond to that. So it's going to be essentially alerting the pancreas, the liver, and a number of other organs secondarily, and also the brain that, hey, we've had food and certain things need to happen. And as I say, both of those incretin stimulate insulin secretion after any oral glucose load. And when someone has type 2 diabetes, what we find is that this incretin effect has become blunted or it's absent. In other words, the things that should be triggering these GLP-1s, the regulation of the system, capacity to be sensitive to the GLP-1, something has gone wrong. So this effect is blunted or it's absent. And the GLP-1 agonists, the drugs that we are talking about that many of our clients are using, they can increase insulin sensitivity. And what's interesting is that they're not deactivated by this dipeptidyl peptidase 4 as rapidly. So in our bodies, normally this enzyme is able to inactivate the GLP-1 in 4 minutes. The GLP-1 agonists, which mimic the GLP-1, they're not inactivated by this enzyme, and they can stay active in the body, in the system for a week. And that's why people who are on these drugs only inject once a week. So that incretin effect and all the things that come with it last very, very long, as opposed to very short in reality, in a system that is healthy and that is balanced as it should be. And that is the reason why these GLP-1 drugs, you only need to take them once a week. So as I said, you're going to be eating something, the gut is registering, and it is from the L cells in the small intestine, it's registering this food, and GLP-1 is activated. It talks to the liver and the pancreas in order to manage your blood sugar. And then there's a host of other signals. As you can see, this is the messiest diagram. But what it is telling us is that you've got GLP-1 receptors in your brain, not only in the pancreas and in the liver. And so signaling starts to happen that has a profound effect on appetite and has a profound effect on how much food we're going to be eating and our metabolism in general. And what we know is that when the GLP-1 receptors in the hypothalamus, so that's in the brain, we go back to our diagram. So we're just setting the scene so that we can really discuss these. When these GLP-1 receptors are activated, that's where all these benefits that people find in terms of their appetite and their desire for food, that's where that comes about. So when they're activated in the brain, we get the release of what we call anorexigenic peptides. You know, anorexia is we're not eating, and so these are the ones that make us not want to eat, and that's part of the pro-opiomelanocortin pathway. And we get a decreased release of the orexigenic. So these are things that make us want to eat. So we have less of the signaling peptides that make us want to eat, and we have a triggering of a pathway that makes us not want to eat, the POMC pathway. And the result is we have a reduced food intake, and because of the way that the pro-opiomelanocortin pathway works, we actually burn energy even though we're not eating. So that's the best thing in the world, is that you actually don't feel like eating and you burn energy in an interesting way. And this sets the scene for the weight loss and for some of the benefits that we see. So I'm not making any judgments around whether these drugs are good or not. We want to look at how do they work and how can we support people who choose to make use of them, or individuals who choose not to. So this slide just illustrates the fact that when GLP-1 is released from the gut, it does have an effect on multiple organs from a variety for a variety of reasons, and as a result of a variety of pathways. The body works as a system. And what's intriguing is that not only are we seeing effects in the fat, better fat metabolism, seeing the liver, there's less fatty deposits there, less production of glucose. We're seeing in the gut slowing down of gastric emptying, so you feel fuller for long, and with that comes, because your gut remains full and stretched, decreased appetite, more satiety. We see the pancreas working better. But what's interesting is that they see increased lung function. There's some evidence that there's some supportive signaling to the bone. There seems to be some neuroprotective effect with the GLP-1 drugs, and our natural GLP-1 does that for us as well. It actually has an impact on our brains. It's neuroprotective, not only in terms of making us not overeat, and allowing us to feel full and happy, but it's neuroprotective as well because of the way that it supports the brain energy production and brain metabolism. And then there seems to be a benefit to the kidneys. Also, there's a cardioprotective aspect. So there's been some benefits to the heart noticed with these medications. Remember, we have these we have the GLP-1s ready and waiting to work for us in our bodies. But if someone needs to take these medications, research has shown some very interesting benefits. And so these somewhat unexpected benefits center around some regenerative properties. There's definitely a decrease in neuroinflammation. There's also benefit in terms of how the joints respond. And again, possibly it's the loss of weight. If used early, there's some evidence that it can actually heal the pancreas. And then, as I said, it's also cardio protective. And the question, again, is this the GLP-1 drug, or is it the cumulative effect of that drug helping to restore metabolic balance and mitochondrial function? And as we'll see later, that these medications do have an impact on mitochondria, just as your natural GLP-1 has an impact. So remember, your GLP-1 drugs are mimicking your natural GLP-1. And so if we look at benefits and risks, the benefits are weight loss, great metabolic health, appetite regulation, neurological health. There's been some evidence that individuals have less addictive tendencies, and then the cardiovascular benefit. And wherever there's a good side, there can be a challenge. And so some of the risks, and many of them are longer term risks, are that with that slow gastric emptying, which is great because you feel satisfied or full for longer. You can also get gastroparesis, so paralysis of the bowels. That can lead to bowel obstruction. In individuals who perhaps have underlying inflammation in the pancreas, these medications can cause pancreatitis, which is an incredibly painful condition, also life-threatening. There can be bile duct blockage. There can be a loss of muscle. So 40% in some individuals of their weight loss will be muscle. And that's not a good thing, because muscle is your most metabolically active organ. And so when you lose muscle, you lose metabolic power. There's been some evidence of neuropathy, particularly the optic nerve. People have spoken about the Ozempic face. So fat pads in the face disappear faster than the skin can tension up and that the collagen can respond. And then there has been some evidence of bone density loss. So what we are beginning to understand is that you will see these risks in certain individuals who are almost primed for them, and in other individuals you don't see many risks at all. In a sense, the sicker the person is, the more they have underlying risks that can be triggered into these long-term risks that we see with the GLP-1 agonists. So again, we might be able to support individuals who are not well to help them to be healthier while they're on these medications, so that some of these longer-term risks don't come to the fore. So again, just a reminder that this is the GLPs are working extensively throughout multiple systems. So just to illustrate one or two of those situations, there have been some studies looking at the impact on the nervous system. A nice decrease in neuroinflammation, obviously changing satiety, and there's been some evidence of protection of the peripheral nerves, maintaining what we call the astrocyte function and metabolic homeostasis in the brain. And there have been some therapeutic benefits in Alzheimer's disease and Parkinson's disease. So GLP-1's actually helping in terms of those two conditions. Also, one of the GLP-1 drugs seems to actually moderate the brain's reward system. So the good news is benefits in Parkinson's disease, benefits in Alzheimer's disease, better brain metabolism and glucose utilization, all coming as a result of these metabolic changes. There's positives and negatives in terms of mood. So in some instances, alleviation of addictive cravings, but in other instances, mood problems. So quite a lot of, again, system impacts reminding us that the body is very complex, and most important to consider that whenever we're looking at any medication that has multiple receptors throughout the body, you're going to see multiple impacts. So something that was noted was that the GLP-1 medications essentially help reduce neuroinflammation and result in alleviating a lot of stress from the brain. And these microglial cells, which are your inflammatory cells in the brain, they get inactivated, and the brain can go on to grow and can restore its structure. So that improved neural structure. Our neural structure is not great when the brain is under stress from inflammation. So it's a nice little illustrative slide. And this applies to any neuroinflammatory condition, so no matter where it comes from. When our brain is under an inflammatory state, our neurons aren't flourishing at all. Another area that we see some intriguing research in is the area of bone health. So although in some individuals we see this important shift when they lose weight, because obesity actually disrupts bone metabolism, and it can lead to the bone being reabsorbed. So obesity makes your osteoclasts eat up your bone. And weight loss can actually not only alleviate the stress on the bones because of the extra weight that person is bearing, but weight loss also results in a decrease in inflammation. And individuals who have got conditions like osteoarthritis, it's very much linked to the inflammation of their whole overall metabolic state. So we see a lot of osteoarthritis and also potentially osteoporosis, not only in skinny people, but also in obese individuals. So the GLP-1 receptor agonists actually reduce inflammation. They can improve bone health, and they reduce the osteoclast activity and promote better bone formation. So we see that in some individuals. And then we see in other individuals that they lose bone and that osteoporosis is a risk. And one of the reasons why that might be is that individuals are not eating, so they're not getting the minerals and the nutrients that they need to maintain their bone. So although the GLP-1s are trying to maintain bone health, the lack of nutrients in the diet is pushing against that. So there has been some evidence of in older adults with type 2 diabetes, when they use the GLP-1 receptor agonists, they seem to get more fragile and they have more incidence of fractures, breaking bones. And the thinking behind this is that they might have lost some muscle mass. They might have lost bone mass because of their previous obesity and metabolic situation. But also, they might be dehydrated and have low blood pressure because they're not eating and drinking. And particularly because they might not feel that they have any appetite, they also don't drink. They might have a protein deficit. And again, that means loss of muscle mass and also low blood glucose. So this is one of the reasons why on the intake form for the vibration plate and also for the photobiomodulation, we would ask if someone is on any of these injectables, because they might be a bit dehydrated, they might have lower blood pressure, they might be a bit weaker. So just something to bear in mind and to mitigate that and keep an eye on them. Just checking if there's any no questions, so that's great. So there have been an increased risk of fractures in your older type 2 diabetics on the GLP-1 medications. and some of the reasons on the screen. So let's talk a little bit about the muscle, and hoping to use the first half an hour to give you an overview of these medications, and then the second half an hour to really chat about how we can work with this and help our clients. But this would be a normal muscle. So just to go through this diagram, there's a normal muscle, normal amount of fat, and a nice normal ratio of different types of muscle fibers. These are immune cells, so you've got an immune system involved in your muscle maintenance, and in your muscle tissue there will be immune cells in and around what we call myokines, your immune mediators and communicators. And when someone becomes insulin resistant, what happens is that they get a lot of extra fat, and they have a lot of immune cells in muscle and around perimuscular. And you get a decrease in your type 1 muscle fibers. So muscle changes when we become insulin resistant. And this is something that we know. Insulin resistance actually starts in the muscle. If they have gradual weight loss, they go back here and everything is fine. If everything carries on, one of the things is in obesity, a person does often become sarcopenic. In other words, they lose muscle because they possibly become more and more physically inactive, and that systemic inflammation makes them lose muscle, and we see muscle wasting. When we look at individuals who have bariatric surgery, or they go on to GLP-1 receptor agonists, so the GLP-1 treatments, what we see is that they also have muscle wasting, and that might be to the fact that they're not eating enough protein, they're not eating at all. There is this very interesting anti-inflammatory effect. So loss of immune cells, not so many immune cells, but skeletal muscle wasting. Unfortunately, if this individual then puts on the weight, they go here where they have more fat and small muscles and more inflammation, and that's a really bad thing. This is what we worry about with someone who suddenly goes off the GLP-1s and they go straight to here. We call this sarcopenic obesity. In the GLP-1s, we see sarcopenia, a slightly different thing. So if we look at what happens with the GLP-1s, 25% of the total weight loss is what we often see when individuals are using these medications, but a significant amount of that, as high as 40%, can be lean body mass, and that's generally muscle. So there's this decline in muscle mass in certain individuals, and often it's people who are already predisposed to sarcopenia. They have the worst outcomes. So those would be individuals who are perhaps very obese and they haven't exercised for a while, and possibly they haven't even been eating enough protein. Possibly they've been eating too much sugar and carbs. So we see this loss of muscle mass. Now remember, your muscle is your most metabolically active organ. It's also actually more a hormone, or not a hormone, a gland. It operates as a gland. It signals to every organ in the body. So it's a key aspect of your metabolism. And so when we lose muscle mass, we get into trouble. So with the GLP-1, something that's really important is that we can preserve the muscle mass, but it needs to be done very, very consciously. And that means a high protein diet, resistance training, in order to mitigate that potential loss of muscle mass during GLP-1 usage. And that's why we can bring both the photobiomodulation and the vibration plate into play to support someone who's on the GLP-1 agonists, or just to support someone who's obese or overweight who wants to move back and restore their body composition. So the slide just illustrates some of the benefits in terms of the GLP-1 medications. They've got a great effect on cholesterol. They've got an anti-inflammatory effect, obviously the metabolic effect, and then they increase nitric oxide, decrease blood pressure. So there's an endothelial improvement, an improvement in the quality of the blood vessels and their lining. And so the GLP-1 agonists are considered to be cardioprotective. We certainly know that many of these things, anti-inflammatory signaling, metabolic weight loss, and also nitric oxide production, is something that we can facilitate with photobiomodulation. So we're winning already. So something that has been of concern is that this muscle loss can extend beyond the skeletal muscle to include the cardiac muscle. So there was one particular GLP-1, the liraglutide, that actually caused reduction in the left ventricular muscle mass. So the heart muscle actually lost some of its capacity, and so they lost capacity of heart muscle, and that predisposed these individuals to heart failure and decreased exercise tolerance. So there's a win and a potential lose. So there's a lot that we still need to learn. And there is a question as to whether the GLP-1s impair what we call the anabolic signaling pathways, which is anabolic, building up and maintaining the muscles. So a concern about the heart. And yet there have been some studies that have shown a very important increased maintenance of muscles on the GLP-1. So I think what it's teaching us is that there are many different people with many different, so we say, genetic predispositions, pre-existing conditions. And so when we bring these kind of medications into play, different people will respond quite differently. So this is just a paper that really looked at some of the important things that we need to actually promote the maintenance of our muscles. And we all know protein, but actually vitamin E and, very importantly, vitamin D are very key to giving that anabolic stimulus, promoting muscle synthesis, and also protecting against oxidative damage and loss of muscle mass. So we need to get our nutrition right. Vitamin D, again, not just taking it as a supplement, but actually getting into the sunshine. This is something that we will talk about. And if someone is having a lower calorie intake because of the action of the GLP-1s on their appetite, and they're not focusing on the quality of the food that they're taking in, they can become very nutritionally deficient, and also as a result metabolically inefficient. And some of the things that we're seeing that are quite important, your copper, selenium, your other mineral deficiencies, protein deficiencies, those also equal loss of muscle. And the current opinion is that older adults may benefit from around 1.2 grams per kilogram of protein a day. And the more active you are, even up to 2 grams per kilogram of protein per day. So what that means is if you weigh, shall we say, 60 or 70 kilograms, that means that you need just around, let's say, 66 odd, maybe up to 70 odd grams of protein per day. Now, bear in mind that any protein, very concentrated protein source, like a piece of chicken breast, it's 70% water. So if you're having 100-gram piece of chicken, you're only getting 30 grams of protein. And if you need about 70, you've still got 40 to go. So you need 2.5 chicken breasts at least if you're going to get your protein. If you're looking at, what should I be eating? Well, it's one chicken breast, which would be 30 grams of protein. Maybe 2 eggs, which would be about 12 grams of protein. So now you're at 42 and you need to get to about 70. So when you think of what people are consuming in a day in terms of protein, most people are way behind. And in an individual who has is on a GLP-1 agonist, they need to get their protein metrics spot on. So high protein diet, resistance training, very important. And there's some evidence that protein supplementation could reduce that risk of fracture, particularly in your postmenopausal woman with osteoporosis. Certainly people could use creatine as well, and whey powder, collagen powders. But a lot of individuals are very under-muscled and under-proteined. So back to one of our favorite little organelles. There are some mitochondrial benefits to the GLP-1 agonists, which makes sense because your GLP-1, endogenous GLP-1 would be benefiting you as well. So GLP-1 treatments in individuals who are requiring it, it improves the redox state of the mitochondria as well as the mitochondrial activity, respiration, ATP production. It's also reducing damage to the blood vessels, reducing inflammation, carotid artery thickness, atherosclerosis, cardiovascular risk. But yeah, there seems to be a benefit to the mitochondria. Maybe that is because of the general overall metabolic recovery. We know that we're looking at getting more ATP produced, more metabolic water, and that's what we're trying to facilitate with our photobiomodulation, so we can support that even further. So we've had a little overview of these medications. One of our big challenges is that many people stop these medications because they can't afford them, because they don't like the side effects. And so this is a fairly recent article, just under a year old, looking at do people stay on these medications? And more than 50% of individuals discontinue these medications within 1 year. When we look at people who stayed on medication, 80% of those often then just used very low maintenance dosages. These medications are not always covered by medical aid, and there were some medication shortages. There's side effects, so individuals might stop, and then when they stop, we get something called a rebound. So an individual who stops will probably put back 65% of the weight that they lost in the next year. So if an individual loses a lot of weight, roughly 65 to 75% of that weight is going to be regained when they stop the medication. So someone has described these medications as a pharmacological appetite straitjacket. You basically in your straitjacket, and when you take the straitjacket off, everything goes south. So remember that appetite regulation and fat storage are evolutionary adaptations, and they're highly conserved. So the GLP-1 agonists are very strongly switching off a very old pathway that helped us to survive. So if we weren't hungry and looking for food, and if we weren't able to store fat, we would die. So hunger and fat storage is what really allowed us as human beings, and for all creatures, it allows us to survive, because then we are motivated to look for food, and we store fat when there are times of famine. What also adds insult to injury when someone stops using the GLP-1s is that they now have lost some of their metabolically active lean muscle. And so they might find themselves metabolically in a very bad place. So people who stop need a workable exit strategy that they would discuss with their healthcare provider, but how can we help? So there are some things that we can do. So coming back to us understanding a little bit about how our mitochondria are involved in every aspect of our health. Remember that all sorts of outside influences, whether it's deficiencies, exposures to things that are stressing our mitochondria, stress, etc., has an impact on how our mitochondria work. When our mitochondria are under pressure, things start to degenerate, and the metabolic diseases are one of those things. Also, when our mitochondria are under stress, we see a lot of inflammation. So this progressive bioenergetic decline is a reality in obesity and in your metabolic diseases. And that's why when you've got these metabolic diseases, everything else falls apart. There's inflammation, there's cancer risk, we age faster, and our heart, our kidneys, and our brain goes down the drain, because it all comes back to our mitochondria going into an energy crisis. And metabolic syndrome is an absolutely clear picture of that. So again, we want to rescue our mitochondria. Most important to get things back online, and for someone who is wanting to recover, whether they are working with a GLP-1 agonist, or whether they're stopping it, or whether they're not wanting to use that at all. They want to recover and get their metabolism back on track. And that's where we can use our photobiomodulation to, again, reactivate mitochondrial function and really decrease damage and death of cells, get that anti-inflammatory signaling going, and increasing the cell metabolism. So back to the slide that we looked at earlier, we can really assist in terms of the inflammation side as well. We know we can assist from mitochondrial support. And this is a nice paper from 2017 looking at how photobiomodulation is reducing inflammation. And here it is, it reduces the markers of M1 phenotype, so M1 macrophages. This is exactly the starting point for the chronic inflammation that we see in obesity. So we can target the mitochondria, we can target that chronic inflammation. So it makes total sense. Anyone who's on GLP-1s should be having access to some photobiomodulation. Not only are we looking at just that mitochondrial and that inflammatory modulation, but we know that photobiomodulation itself is helping to reduce blood sugar, and it's actually having a positive effect on the beta cells in the pancreas. So it's also assisting in pancreatic function and pancreatic recovery, as we see with the GLP-1s. And we see very good results with photobiomodulation, not just in the measurements of the body, the anthropometrical measurements, but also psychological and physiological parameters. I want to share some research with you. we've seen this slide before, just the fact that the mitochondria in the fat cells are activated by photobiomodulation, and that stimulates the natural cell death in the fat cells, but also the using up of the fat stores in the fat tissue itself. So fat cells are naturally eliminated and put to sleep and put to bed, and also those that are remaining are using the fat stores. So that's the same slide. We know that photobiomodulation has an impact on insulin resistance. It improves insulin sensitivity, and particularly if it's combined with exercise. And then also it seems to have an impact on the gut microbiome in a very positive way. And we know that there's a link between obesity and dysbiosis. So we're hitting a couple of targets here. This is an exciting study looking at non-alcoholic fatty liver disease in men. They were doing some aerobic and resistance training. They were obese individuals. They were also doing photobiomodulation treatment, and they had an improvement in all of these parameters. So their cholesterol, their triglycerides, the free fats, the insulin, and then these are their liver enzymes. And so really there was some evidence that you could treat non-alcoholic fatty liver disease using photobiomodulation. And also here, some very important side effects, positive side effects in looking at diabetics is that not only is it good for diabetes as a metabolic condition, but also the complications, your neuropathic and nephropathic kidney symptoms. And it can be used to help people with those neuropathies and reducing that risk of amputations. And again, another great paper that's just looking at photobiomodulation to initiate or help offset excess weight, balancing inflammation, helping to manage the diabetes. So this was really looking at photobiomodulation as an adjunctive treatment in an obesity management program. So it helps people to start losing weight when they've really been struggling. It can help people just get started. So great research there. And then remember that someone who's coming to get some red light therapy, they might have problems with mobility. So, they don't want to go to the gym, or they're too intimidated to go to the gym. So they can use the vibration plate and your light. And it's been found to help individuals have less of a need for medications, as a result of their inflammatory problems. So people are taking less drugs, they're sleeping better, their mood is better. And you could also decrease the need for bariatric surgery, but also it increases immunity and wound healing in the case of surgery. So again, we can offer a lot of benefits. Just reminding you of the discussion we had about individuals who are on the GLP receptor agonists getting their challenge with sarcopenia, and we need high protein diet. We need to help them with resistance exercise. Remember that the action of the photobiomodulation on the mitochondria is mimicking exercise. So when we're using photobiomodulation, it's not just making us better at exercising. So it's not just a performance enhancing stimulus, but it's an exercise mimetic. It mimics exercise. It activates all the pathways. The mitochondria are being exercised. So as a result of that, we see people maintaining better muscle mass just from photobiomodulation. You can combine it with a vibration plate, and you get an even better outcome. So some great research that's looking at the combination. Excellent for our individuals with the GLP-1s. And again, using the vibration plate, we're stimulating the nervous system in the brain and reactivating the musculoskeletal system. So it's really going to be a benefit for our individuals who might be using GLP-1s. It has been studied in terms of metabolic syndrome, and it is deemed to be safe, well acceptable, and a very good intervention. So I always like to mention the ICU study, because there we had individuals in ICU. They weren't able to move much. They had their photobiomodulation therapy, and it reduced their stay in the ICU, but their muscle strength by hand grip actually went up. They increased their muscle strength. They increased their functional capacity. And they increased another measure of muscle strength. These were the controls who lost muscle strength. These were your study population. So photobiomodulation is sparing muscle. So it's a great option for your individuals who are using the GLP-1s. But for anyone who needs to activate that very important metabolic organ. And then we spoke about nitric oxide and the impact that the GLP-1s have on increasing nitric oxide. Photobiomodulation does the same. So just a reminder that we have able to offer people a lot of benefits. So your photobiomodulation by your red and infrared light is activating that nitric oxide reservoir that then goes on to support the lungs, immune system, blood vessels, mitochondrial activity, muscle performance, and is also very neuroprotective. So again, those unexpected benefits that we see from the GLP-1s, again, possibly it's to do with restoring that metabolic balance, but we can offer all of these with photobiomodulation as well. And looking at, again, these are some of the things that photobiomodulation is assisting. All the same things that they're saying are the great sort of collateral benefits of the GLP-1s. So I want to do a little, play a little mind game with you here as we close off. So we've seen this slide when the GLP-1s activate the receptors in the hypothalamus in the brain. You get the release of anorexic, shall we say, peptides, ones that make you not want to eat, and you get a decrease in the release of the things that make you want to eat, neuropeptide YY and the agouti-related peptides. So you don't eat, and naturally your energy expenditure is switched on via the POMC. So here's some research on ultraviolet B light, and it's stimulating the same pathway, the POMC pathway, in the hypothalamus. And you get the expression of POMC and the melanocortin receptor. And this agouti protein, the AGRP, was inhibited, same thing that the GLP-1s do. And you get an increase in the number of your of both your alpha MSH and your melanocortin 4 receptor. And those are your appetite suppressants. Increased levels of alpha MSH and beta endorphins. Alpha MSH increases your metabolism, and beta endorphins make you feel really happy. You don't crave stuff, both in the hypothalamus. And this is via UVB light. So sunlight does exactly the same thing as GLP-1s. So just give some thought to how much sun we're getting and why we're so obese. Maybe we're not getting enough UV light. So sunlight is really, really important. So this is the key researcher in the field that looks at our skin as a neuroendocrine organ, and UVB stimulating these neurons in our hypothalamus, the arcuate nucleus. We're getting this alpha MSH, which suppresses our appetite, increases our metabolic rate, and we feel great because the beta endorphins help us to produce our dopamine. And here he says, this paves the way for exciting research on communication between the skin and the brain, and suggesting a new role for UVB in the regulation of body metabolism. So go and dig around into sunlight and metabolism. Because the skin is an endocrine organ. So UV light touches the brain and the endocrine system. I wanted to throw that in because I think we do need a holistic view on this. So sunshine resets our body's homeostasis, and it has a very important therapeutic effect. Remember, our mitochondria are essentially photosynthetic purple bacterium. Back in the day, that's what they were. They are keyed into light. And we know that when there's not enough UV light and our vitamin D is low, we are at risk of obesity and metabolic syndrome. So there's a protective role for UV, excuse me, UV light and sun exposure in reducing obesity and cardiometabolic dysfunction. Artificial light is not great. So a woman who slept with a light or a television on, 17% more likely to have gained 5 kilograms over a follow-up period of that research. So natural light, not artificial light. So in conclusion, just to remind you that we are very complex. Mitochondrial function is at the root of much of what we need to address. And I need to move that. We really need to get the right lights. So great. I hope you have got a lot of food for thought. I'm going to stop sharing and take a couple of questions. So thanks for your attention.
Thank you, Dr. Margot. That was absolutely insightful and super interesting. I loved every moment. Cool. If anyone still has questions, continue to put them in the chat. I will read them out and Dr. Margot can answer them. Also, keep your eye on the chat. I'll be posting a nice freebie for everyone in a moment. And then also I will post an email address if you would want to reach out and ask more questions. So firstly, Dr. Margot, would someone who was diagnosed with osteopenia benefit from both the vibroplate and photobiomodulation?
Yes, so that's a question from Shelley. Absolutely, Shelley. So osteopenia is the very early stage of osteoporosis. So there would be no concerns from the vibration plate at all. And yes, we know that that photobiomodulation has an impact on bone metabolism at the level of your kind of bone stem cell stimulation. So absolutely. And I would say that they're a perfect candidate. I've got the questions up here.
Okay, yeah.
Because I want to rush ahead and check them out so I can prepare myself.
Perfect.
Where could one buy GLP-1s? So these are on prescription. from the medical practitioner. So they're on prescription, and individuals would then be and need to be monitored. And I think a lot of doctors are prescribing them now. Can it be used for patients with hypercalcemia? I don't know if that's the photobiomodulation or the vibration plate, but individuals who have hypercalcemia, if it's caused by high or if it's caused by problems with their vitamin D and bone metabolism, they could have brittle bones. So I would recommend that they get cleared by their doctor, because they might have brittle bones. That's one sometimes has some syndromes like that. Kara's got what would start with 10 minutes hypervibe, with the 5 minutes before, 5 minutes after. Yeah, the 5 minutes before, 5 minutes after is still a really good combo, so I'd recommend that. There's something beneficial to having that stimulus before and after. Eat before or after a session for maximum metabolism. Eat after, because it's quite it can be quite beneficial if you can handle it to be in a somewhat fasted state, so that you can burn your fat, not the sugar that you just put on board. But if someone is a diabetic, or they have blood sugar and on blood sugar lowering medications, then you don't want them to be fasted, because it might push them over into hypoglycemic state. So just being careful about that. Kilogram restriction on the vibration plate. I don't know it off the top of my head. I do recall.
That's,
yeah, thank you.
It's 200 kilograms. Awesome. I checked.
Excellent. Thank you for that. Excellent. Client has had knee replacement, wants to do weight loss. Can they use the hypervibe? What do we recommend them to do? So it depends on when they had the knee replacement. So if it's within 6 months of the knee replacement, no. If it's after 6 months, with permission, make sure that knee replacement is well settled. Everything is fine. What they can do is they can do the red light, and that would have a metabolic benefit in and of itself. Just remember, most of the research that we have regarding metabolic fat loss with photobiomodulation is just with the light. It's not with the vibration plate. So from that perspective, you can get really, really good results just with that light. So I like to just say to patients, really don't worry, because you're not losing out. The stimulation of the mitochondria with the photobiomodulation is spectacular. So the red light is doing a ton of things. The vibration plate is a beautiful addition, but most of the research in fat loss is just with the light. So yeah, good question there, Llewellyn. If GLPs have a positive effect on the metabolism, does that not suggest mitochondrial stimulation from the drug? Why would the light and the GLP-1 not overstimulate the mitochondria? So yeah, all sorts of things that we have to think about and learn about. So bearing in mind that these medications have been used back in the day. So we're looking at easily about 13 years ago, if not 15 years ago. They were only used for diabetic treatment. So they were only used for diabetes. In being used for diabetes, you now have someone with a overall metabolic problem that is systemic. And so anything that alleviates the pressure on that system will have a benefit to the mitochondria. And what we know is that just losing 15% of your total body weight has an 80% impact on your actual metabolic health. So you don't have to lose a lot of weight. And what's also been studied is that when you lose weight, you lose skin surface area, and just losing skin surface area has a profound effect on your overall health. And this is at a metabolic level. So these drugs have been used for a long time in the context of diabetes. They've only been used in the context of obesity in about 3 years. Now, obesity, not every person who's obese is diabetic. And not everybody is using GLP-1s is even obese. So you have a lot of people who are using it just because they want to maintain weight without having to do a lot of extra work. They might just want to have, they just might want to look extra slim. They find that, maybe their metabolic health is not what it can be, so they're using the GLP-1s to keep weight off. And so many aspects of our lifestyle are actually getting in the way of us not having a balanced metabolism. And one of it is that we're not out in the sunshine getting our UV light. It's a deal breaker. That's why we need these GLP-1 drugs, because we're not getting the stimulus from the UV light that we should via the skin, which is one of our biggest organs. But let me pull back my rant and answer Llewellyn's question a little bit. So Llewellyn, we don't know as much about using the GLP-1s in the context that is being used currently. There's evidence in some people that it helps the mitochondria, and there's evidence in other people that it doesn't help the mitochondria. So we're looking at, and there's been a comment that depending on your mitochondrial haplotype, there might be a different response to the GLP-1s. What is the mitochondrial haplotype? That is the genetic, your mitochondrial DNA that you got from your mother and that you got from her mother. So where your mitochondria come from on this planet can have an impact on how your mitochondria respond to these medications. So it's quite complex. And do they overstimulate the mitochondria? So that's a really good question. So we know that photobiomodulation can overstimulate mitochondria because the mitochondria, in being stimulated, make a lot of reactive oxygen species. Perhaps that mitochondrial metabolism is not as efficient as it could be. So you stimulate your mitochondria with the photobiomodulation, and the mitochondria make more reactive oxygen species to a point where they switch off the electron transport chain because they don't want to make any more reactive oxygen species, and they start to make heat. And that's when your client overheats under the light. So could the GLP-1s overstimulate the mitochondria? I don't think so, because we don't, and I've not seen the mechanisms of them in mitochondrial function yet. Something I probably need to go and dig into. So that's a nice little pathway I can go down. So could the GLP-1s overstimulate the mitochondria? I don't know. Interesting idea. Always a good question that sends me down a rabbit hole. So thanks for that one. Can photobiomodulation assist with vitiligo, from Christine? So yeah, just a couple of general questions, seeing that you got me on the line, which is cool. So vitiligo is an inflammatory, kind of an autoimmune based condition in the skin. So there's a possibility that it will help with the inflammatory component, but it's a bigger systemic condition as well. And so red light is and infrared light is not the only wavelengths that are needed. Shelley's got a good one there. What about someone with a prosthetic leg? So we know individuals with leg prostheses do all sorts of interesting sports. I presume you're thinking about the vibration plate. I would say they should take their prosthesis off and exercise all the other muscles, not use their prosthesis if they're on that vibration plate. So let them balance in another way. Great. Prior injury. So Lola, yeah, some clients who've had injuries complained that they were sore on the hypervibe. Yeah, I think remember the hypervibe is hyper. It is a robust treatment. So start very slow. If someone complains that they're sore, their muscles might not be used to being stimulated. So what I recommend is just start really slow. For some people just don't like the hypervibe. That's okay as well. So listen to your clients, inquire, start slow, work around things. And how long does photobiomodulation continue to work in the body after a session? That is such a very cool question, because they've done some studies around that, looking at the actual production of shall we say, the production of components of the electron transport chain, and the activity of the electron transport chain after the photobiomodulation. And in some of their pieces of research, they saw up to 2 weeks. One session still has metabolic effects up to 2 weeks. So I must actually dig that paper out and talk about it sometime. That was very, very interesting. So yeah, one session has an extended impact on metabolism, which is awesome. Great. I think we've come to the end of our questions. Excellent. Thanks, everybody. As always, we'll have this video online for you, and we will look forward to seeing you for the next Smart Talk next month. Cool.
Thank you so much. Thank you, everyone, for being here. Yeah, enjoy your evenings. Bye-bye.
Bye.